Okay, good afternoon, everybody. I'm Maureen Stevenson. I'm Patient Safety and Improvement Manager for NHS Dumfries and Galloway. I've been a passionate improver for all of my career, which is very scarily now more than 30 years. And I'm a speech and language therapist by profession. So I want to firstly welcome you and thank you for all of the contributions that we had to the QI poster competition. So we've ran this for the last 3 or 4 years, and every year we've had more and more entries. And I think that that's absolutely fantastic. And what we've seen in those entries, and we got 41 this year, so we're down to 5 to present orally today. So big congratulations to everybody who entered, but also to those 5 that have been chosen to present today. And what we're seeing is something from every stage of the improvement journey. So from people identifying issues where we need to do some improvement work, or we need to think about how to do something that's different from what's currently happening, so perhaps a more traditional audit project, to ones where they've actually followed an improvement journey right the way through to the end and are able to demonstrate results. Some of them demonstrating improvement, some of them demonstrating that they need to do further improvement and that they're not at the end of that journey yet. So I think that there's some fantastic things there. It's been a multidisciplinary thing. We've had engagement from some of our medical students. Some of them are presenting today. So huge well done to you guys for showing us the way and how to do quality improvement. And we've had entries from all different care professions as well. Huge number from our junior doctors, which is great to see, and keep on that improvement journey. And that's probably all that I want to say today. I think in terms of where we're going as a board and as an NHS, it's about, you know, us coming into work to think about the job that we're doing today, but also to think about how do we make sure that we're continually highlighting the issues that are perhaps getting in the way of us delivering good quality care, and those things that we need to improve. So it's that balance between doing what you need to do, noticing what needs to be improved, and purposely working with others to make those improvements happen. Ultimately, we're all consumers of healthcare, and I want a really good service when I pop off into my retirement, and I'm relying on you guys to keep the side up around that. So I'm going to hand over to Professor Chris Isles, and Chris is going to say a few words and get us started on the programme this afternoon.
Greetings, everyone. My name is Chris Isles. These are very few words because I don't want to waste time, and really looking forward to hearing all the talks. Just to let everyone know, there were 41 posters submitted, which is a stunningly good number. At least 8 of them followed true QI methodology. And there were some very good posters, those that didn't follow QI methodology. We've got approval from the College of Physicians of London for 4 external CPD credits for those of you who viewed the posters online and coming to this meeting. So I'm going to kick off straight away with Caitlin Elliott and Harry Johnson. It's a double act, I believe. And they're going to talk about gentamicin, are we prescribing safely? Message for all the speakers. I'm hoping for 10 minutes talk, 5 minutes discussion. If you get to 12 minutes and you're still talking, I'm going to say, I'm going to interrupt you nicely.
Do we keep masks on, or can we take them off? So thank you very much for having us. I'm Harry, one of the FY1s in surgery at the moment.
Caitlin, I'm one of the FY1s as well. I'm in medicine at the minute.
And we're going to present our poster on gentamicin prescribing. So for those of you that have seen the poster, for those of you that haven't, we identified an issue quite soon after starting FY1 that gentamicin prescribing wasn't greatly done. Gentamicin is a strong antibiotic used in certain infections. It's used quite a lot throughout the hospital, mainly at the front door. It's a drug that needs close monitoring due to side effects. The main side effects that we need to be aware of as doctors are nephrotoxicity and ototoxicity. Things like ototoxicity can have strong medical legal implications because if patients lose their hearing unnecessarily, that's not ideal. So we need to get doses right, and we need to make sure that the levels are taken within the right intervals. We noticed that lots of patients weren't having levels done and dosing errors made. So our main outcome of our audit was to improve the overall accuracy of gentamicin prescriptions. That's in terms of getting correct dosage and dosage intervals and getting levels taken in the right timeframes. We also wanted to improve the monitoring of gentamicin in terms of daily creatinine levels, which is one of the requirements on the gentamicin prescription chart. We wanted to improve the documentation of the gent prescriptions and try and work out some basic themes as to why patients were, or why gent prescriptions weren't getting done properly.
So just in case anybody's slightly less familiar with the gentamicin charts that we use here, I know they have slight variations in different hospitals, but we popped up a chart here of the specific things that we were looking at as part of this audit. And I've circled the 4 key areas that we were having a look at to make sure that these parts of the chart were filled in correctly. And it sounds very sort of secretarial, but actually this can reflect how well people are paying attention and are we actually checking the gentamicin levels in order to fill in the monitoring record correctly? Are we making sure that there's a creatinine level in order to fill it in correctly? And without that documentation, we can't say for sure, and we probably wouldn't have a leg to stand on if anything went a bit wrong. You'll notice also on the far left, it's not actually projected up quite as nicely as I wanted it to. We've just underlined there, it says on the current charts to check a gentamicin level at least every 2 days. And that's something that we might circle back to in the discussion at the end. So in terms of methods, we've tried to set this up a bit like a paper. So to keep it simple, I've tried to put some pictures up. We started off our study in October and we collected a sample from everybody who was prescribed gentamicin on Hepma for the entirety of October. We had some very lovely, helpful pharmacists who sent us all of the raw data for those patients and the CAI numbers, and then we went through on portal and manually went through and collected the data, looked at the old charts that were available. We did the same again in March, but because it was a re-audit, we scaled it down, so it was just for the 1 week. So we had 102 patients from the entirety of October that ended up being in the final results, and then 31 in March, which multiplied by 4 is roughly equivocal at the end. Put in a few exclusion criteria, they're kind of self-explanatory of if we couldn't find the data, then we couldn't analyse it. So we took out a few throughout. So we made a few interventions. A lot of this was on the poster if anybody's had a chance to have a look at it. The key things that we really wanted to do was get a high alert tab on Hepma. We do a lot of our prescribing through Hepma, and it's quite easy to click a few buttons and it comes up automatically. Again, with the help of some wonderful pharmacists, we've been able to put on a high alert tab. So from looking from a distance, you can see that you should be paying attention to this drug. And when you first go to prescribe it, there is a warning that says it's the prescriber's responsibility to make sure that we're checking daily creatinine and daily gentamicin level, and please can you make sure this is on order comms. When we introduced this on Hepma, we then brought out some posters, and these were displayed in the high traffic areas where a lot of gentamicin is first started, so SAU and CAU, and a lot of our FY1s are the biggest prescribers. We thought the doctor's mess might be a good shout as well. And then lastly, obviously, you guys are all gathered here because we are presenting, and that in itself is a bit of an intervention because we're providing that next level of education. So in terms of results, we've tried to summarise the key data points here, but essentially from October to March, we found that there was more patients who got the correct first dose, having been calculated correctly using the right creatinine and the up-to-date weight. This one is a bit of an interesting one. So we found that the number of levels taken outside of the appropriate 6 to 14 hour window reduced. So that's that grey box here. But that comes with the caveat that actually more levels were just not taken at all when they maybe should have been. And that's overall from a first, a second and a third dose, overall less levels were taken. So the summative value of how many levels were correctly taken doesn't change all that much with the blue. Incidentally, because we were having to look at the portal notes to see if they were available, we did notice that actually we weren't scanning in the charts and keeping a hold of these charts, which have a record of us monitoring the gentamicin levels and the creatinine and the renal function. We weren't uploading them as well, so it was a bit harder to analyse in March. The eagle-eyed of you will notice that those numbers are ever so slightly different from the poster, and I'll put my hand up and say that's because I made a slight calculation error. The difference between the two is still 10%, so there's still a 10% discrepancy in that 10% less were uploaded, but the numbers are ever so slightly different. My apologies. And then lastly, we did notice a big improvement in how many charts were actually filled in correctly. So thinking back to that gentamicin chart at the start, how many blanks were now filled in compared to at the start. As we were going through, we noticed some common themes that we started documenting down. And like we keep coming back to, it's really that monitoring record. So the three that really stuck out were missing creatinines, missing monitoring records where maybe a gent level has been taken, but it's not been documented anywhere, and being given at the wrong time. Now, obviously that depends on how busy a ward might be. There are fair enough reasons for that, but that can then have a delayed impact if the gentamicin level has already been requested on order comms. And I'll hand back over to Harry.
So yeah, I'm just basically going to summarise what we've seen in the chart. So overall correct gentamicin doses, and the first dose that we give improved by 9%. And the number of correctly completed gentamicin charts, like Caitlin said, all the blanks that should have been filled in were actually filled in, improved by about a quarter, 27%. Of all levels that were taken, we managed to reduce late levels by 22%. However, this figure isn't exactly true because some levels weren't taken at all. So that, you know, we can't really say if that's for sure. When we narrow it down to levels that were actually taken within the window that they were supposed to, it did increase ever so slightly at 3.5%, which, if extrapolated to lots of patients, you know, probably would amount to a difference. The proportion of records that we found uploaded to portal actually decreased by 10%. We're not really sure why that happened, but it's probably one of the main reasons that we have to work on, because we need to retain these prescriptions if they're ever needed. The most common prescribing errors that were identified were missing a monitoring record. It wasn't circled, you know, what the dosing interval should be. Doses were given at the wrong time, and that's important for levels, but also, you know, if patients need urgent antibiotics, say if sepsis is supposed to be given in 1 hour, a lot of patients weren't actually given those antibiotics, and there's definitely an area for improvement. And missing creatinines, which is one of the stipulations of gentamicin monitoring. So there are a couple of strengths to our audit, and we did manage to collect a good number of patients who were given gentamicin, 130. We monitored in both October and in March to avoid the main kind of COVID crisis, because we know that the busier hospital might have meant the prescriptions weren't as great as they should have been. We collected data from both here and the Galloway Community Hospital. We tried to include as many patients as we could, and there's an identifiable issue that we were trying to fix. Weaknesses, so re-auditing at 6 months means that a lot of the prescribers of gentamicin might get better just through clinical experience. You know, FY1 prescriptions in August are not going to be as good as they might be in March. Due to time constraints during COVID and generally our day-to-day working life, it was difficult to introduce these interventions separately, so they're all introduced together. Therefore, it's difficult to say which interventions actually made a difference and which didn't. The other thing is that a lot of gentamicin is given in the emergency department and prescribed in the theatre. Now, these two areas don't tend to use gentamicin charts, and the emergency department don't use HEPMA, therefore we can include these patients. So, things to discuss. Gentamicin was poorly prescribed, and to be honest, I don't think we've made that much of an impact. I think there are many more improvements that we could make, but I don't think at this stage we can definitively say that we actually made a difference to patient outcomes. There are lots of different reasons for calculating doses at the start. Patients frequently aren't weighed on admission, usually due to workloads. And for patients that need antibiotics urgently, we don't have time to wait for creatinines to come back. The main intervention that we'd like to do in the future is be able to prescribe a gentamicin level akin to check blood sugar levels that you get for patients on high-dose steroids. There's some difficulties organising this with pharmacy, but it's something we're still trying to work on. We'd re-audit it when we can introduce that. The gentamicin charts are a bit cumbersome. There's a lot of writing on them that probably doesn't need to be there, so we'd hope to simplify that in the hope that people fill them in better. And there's human factors, things like making sure that every ward is aware of all the patients who are on gentamicin. It just makes that life a little bit easier when working out when, who needs levels when. And we really need to hammer it home that gent charts need to be properly filled out in all areas of the hospital. That includes theatres and the emergency department. Our ultimate hope is that vancomycin, similar antibiotic that requires monitoring and documentation, is also pretty prescribed, and we'd hope that whatever interventions we've made for this project, we might be able to also introduce and re-audit for vanc. I'd invite any questions you have for us.
Very nice, very nice. Guys, if you just stay there,
Okay.
we'll be answering questions. So it's open for discussion, and nicely kept the time, by the way. Yeah, we'll start. You have 5 minutes for discussion.
Some hands
Yeah.
on the screen for you.
Oh, good. We've already got a question. I'm sorry, I don't know your name.
I might not know, you probably don't know.
Hello.
Where do you think, what's the area where there's the greatest likelihood of getting improvement if you to do a further project?
In terms of area of the hospital or area of the prescribing?
Whatever you think. The greatest benefit to be getting.
I have an opinion. So I think the best place that we can improve on is getting the levels taken within 6 to 14 hours. And that then has a knock-on effect into how well we're re-prescribing it and monitoring it as a whole. And if we are focusing in on trying to target that time window a bit better, then it kind of has a knock-on effect to everything else. So you're more likely to be checking a creatinine level daily if you're also checking a gentamicin level daily at the appropriate time. And then you're filling in the monitoring chart correctly. And ultimately, patients aren't getting more doses or too few. Yeah, that was a lot of words.
We have a question from the online people. George, can you speak?
Oh, hi, George.
Hello, lovely presentation. Thank you. I missed the beginning. Apologies. It's this. I'd love the answer to this question if you could give it. How do we get over things like poster fatigue and alert fatigue? Because even I see that you've got a red alert on the HEPMO, which is great. I'd never actually come across those and didn't know they were a feature actually. But even the nurses talk about notes and the pharmacists talk about alert fatigue. Do you think there's a way we can get around this? Because the number of notes and alerts and pop-ups that are immediately dismissed is quite a few, I think.
Yeah, so that was one of the main worries we had about adding anything on HEPMA, because we know, you only need to watch anybody prescribe anything on HEPMA. It's very quick. People tend to gloss over these things, actually, and I suspect that's one of the reasons why. I think we probably just need to make sure that people are actually aware of the implications of poor gent prescribing, and that probably applies to other antibiotics with, a narrow therapeutic index.
Can I just pick up on that? Who isn't aware of the dangers of gentamicin prescribing? I mean, every single person will know it can cause nephrotoxicity and ototoxicity. So it's difficult to imagine that we can become any more aware, but despite our awareness, we're still not doing it properly. And this isn't the first audit or improvement project to show this.
Yeah, I mean, that's true. It's one of these things that you're taught at the start of medical school. It has those classic side effects of somebody losing their hearing after giving too much gen. I don't know, maybe it's because of the fact it's prescribed so often that, and it's, these side effects are actually very infrequently experienced. So that
I was intrigued by your prescribable gentamicin. What exactly did you mean? Prescribable levels, I think.
Yeah, so people might be aware of, so for patients on high dose steroids, there was a previous QI project that allowed you to prescribe a check blood sugar levels, which meant that people, the nurses knew actually to check blood sugars. We were hoping that on HETMA we might be able to prescribe gentamicin level for 6 to 14 hours after the gentamicin was supposed to be administered, so that it would flag up to the nurses that if a level hasn't been taken, that they need to find somebody to take a level, whether that be a phlebotomist, healthcare assistant, or one of us.
Yeah, it gives everybody a bit of power and to help filter it. But I don't have a solid answer for George's question, because I think there are so many projects and we're constantly trying to push healthcare improvement that we can only hope to keep reiterating our point.
No, thank you very much.
This has been an area of high-risk prescribing forever. How do we make sure this isn't a thing for the last 20 years of my career as it has been for the first 20 years? Going into the new, what do you recommend we do?
Yeah.
Good question.
Okay, quick answer.
Quick answer. I think you've covered it. That's good.
Okay, so
I think reiterating.
Pharmacy, and he's one of the judges, so you just in case.
Yeah, that's okay. I think we have to keep reiterating it. I think there are some topics that it seems quite boring and monotonous, but there's a reason why we keep reiterating it. And there's throughout everybody's career, somebody's going to have a passion about something, and I'm quite happy to be the gentamicin lady if that's what it takes.
The gentamicin queen. I'm going to close it there, and thank you very much. Okay, and we're going to move on now to Laura Lennox. Laura, can you access all this for us? So just for everyone else, Laura is a speech language therapist and an AHP lead, and she has a project called Building the Infrastructure for AHP's use of social media in the practice context. How do we support safe and effective use of social media towards quality care? Laura, can you take over from here?
Hello.
Hello, Laura.
Well, that was some entrance, wasn't it? I'll just see if I can share my screen. So, thank you for inviting me along today to present on this quality improvement project. I have to say, first of all, that the implementation of this project was very much a team of contributors, and my role is just here as the representative today. I am representing many others. My name is Laura Lennox, and my background, like Maureen, is as a speech and language therapist and also as an improvement advisor. I've just recently moved into a new post as the Allied Health Professions, so that's AHP, Practice Education Lead. And the Allied Health Professions, or AHPs, if you're not familiar, are made up of 14 different professional groups, of which there are 8 hosted here in NHS Dumfries and Galloway. And the reason I'm mentioning this is because although AHPs make up the third biggest part of the workforce after medical and nursing, not everyone is familiar with the professions within the AHPs and the impact of what we do. So part of this project was exploring the use of social media as a platform, and it was aligned with a national drive to raise the AHP profile. So this included identifying any potential enablers and barriers for AHPs to use social media in their professional practice, and then we used this data to inform our improvement around safe and effective use. But firstly, fingers crossed, I'm going to share a promotional video that we created as part of one of the project change ideas as a means to engage AHP staff as part of that first step in the quality improvement journey around creating conditions for change. So why should AHPs use social media? So this is the driver diagram with our aim, our drivers and our change ideas, which we use to help us map our measurement plan of outcome, process and balance measures. The first phase of the project was from May 2019 to May 2020. And it was part of my Scottish Improvement Skills course hosted by the Patient Safety Improvement team. The aim at that time was primarily to improve the quality of use of social media among AHP staff in Dumfries and Galloway in terms of being safe and effective in their professional conduct. And this was using the data around what AHPs told us were the enablers and barriers, as I said before, to inform our improvement. But we also measured the quantity or the number of AHPs who engaged with the change ideas from a baseline of early adopters, and we were looking to improve to an early majority. So most people heard about the social media labs that we ran and as part of learning and development sessions. But as you can see, there are a great many other change ideas too. Including the use of a local hashtag, which you may have seen on Twitter, hashtag AHPDG, and towards creating an online community of practice. So this is the results. The qualitative data in the Twitter Wordle is demonstrating what AHP staff told us were the enablers and barriers to social media practice in their workplace. There's also some feedback on the outcome of the change ideas. I'm not sure if you're seeing that slide, but if I just tell you, Gemma, she's a physiotherapist, and she was sharing that the online AHPDG presence was making her feel much more part of an AHP community than just physically sharing an office. And that feedback really made my day. It made me feel proud as punch. The quantitative results, they were showing, indicating improvement over time in relation to the various social media measures that we had. So whether or not you can see it, I don't know, but there was an increase in professional use, an increase in writing blogs, an increase in people accessing the national AHP Scot blogs, and there was a significant increase in people using the hashtag AHPDG when they were using social media. So in conclusion, the results were highlighting the number of people who attended the social media labs, and this was representing a shift over time from that early adopters to the early majority of AHPs in Dumfries and Galloway, as per the diffusion of innovation curve. So we did manage to meet our aim. There will be many more AHPs in Dumfries and Galloway who are using social media than just in these figures, but we've only included the ones who we know have attended the social media labs, because then we can confidently declare that they are safe and effective in their online professional conduct for this reason. So the conclusions that we came to was that AHPs can use social media safely following some learning and development opportunities, and that thereafter AHPs can use social media effectively to engage in many things such as continuing professional development, shared learning, networking, being part of an online community of practice, and all of these things which work towards raising the AHP profile, which was the ultimate goal. And if you don't believe me, then I've got a slide here which just demonstrates AHPs in Dumfries and Galloway using the hashtag AHPDG on Twitter. It might be really difficult to read that if you can see it, but there's a few examples just to highlight. So Sarah Hodgson at the top and in other tweets, she was tweeting on AHP's Day about physiotherapy and what physiotherapists do. Joanne from Speech and Language Therapy at the top as well was tweeting about how she is using Twitter as part of her continuing professional development. Alice Ann is an OT from the STARS team, Rehabilitation and Reablement team, and she is tweeting to direct people to the blogs that her team have written. And my favourite of all is on the left-hand side. It's quite a small one to read, but it's from a member of the public, Team Catton. She's thanking the Speech and Language Therapy Adult Service for being a fantastic support to her mum who had motor neuron disease. And it's remarkable that we're now receiving feedback around patient experience in social media, but that she has also picked up on the fact that we're using hashtag AHPDG because she's used it in her tweet. So it's just sort of demonstrating lots of different ways that AHP staff, but now also the public, are using social media to raise the AHP profile. So what's happened since May 2020 until now, you might ask? Well, we had phase 2 of the project, and I was approached by NHS Education Scotland to participate in the NMAP Digital Leadership Programme. They wanted us to share what we were doing in Dumfries and Galloway with other AHPs across Scotland. And we came up with the idea of creating a social media toolkit as part of the Quality Improvement Scale Up and Spread plan. It includes an evidence review of the research literature, the quality improvement tools that we used in Dumfries and Galloway, and also a facilitation of learning package, which allowed others to recreate the AHP social media labs, as well as there being lots of other social media resources, things like local and national policy and guidance. So far it's been tested with AHPs in Forth Valley, Ayrshire and Arran in the Western Isles, and also with occupational therapy students at Glasgow Caledonian University. So the feedback has been positive and it's been incorporated into the toolkit as we speak, and the final draft will eventually sit on the NES TURAS platform, hopefully at some point later in this year. So I'd like to think that this presentation has evidenced how our project has developed over the quality improvement journey, and that this is still not the end. I don't think this project only has relevance just to AHPs. I think there is potential for spread across other disciplines too and other professions. NES are already talking about the social media QI toolkit as being a bit like a Once for Scotland sort of guidance educational package. So we just need to watch this space. And if I can click to the last slide, I don't know if you can see it, but it says, when it comes to social media, empower your staff to be the voice of the organisation. They've got audience and credibility. So there's a picture of a small fish and then a school of fish. Employees have 10% more connections than corporate social accounts, and that's from Horizons at Horizons NHS. So it was just to add, if you're still left wondering why you'd want to use social media in your professional practice, or even what its relevance is within health and care, then this slide just demonstrates why. It's not if we use social media, it's when. So we might as well start preparing everyone to use it safely and effectively. So thank you for taking the time to listen to the presentation today, and I'll stop screen sharing. I don't know how much you saw, but hopefully I'm going to kick off an almighty social media revolution. Thank you.
Laura, thank you for that presentation. Sorry about the technical problems at the start. Now, we have already overrun, so you're going to have to forgive me. I'm going to move on to the next presentation because we're already a couple of minutes over. But thank you very much indeed for that.
Thank you.
Next presentation is by Omar Hassoun, one of our two ScotGem students. We're delighted to have had in Dumfries and Galloway for the last year, 2 years. So Omar, you're going to talk to us about monitoring of testosterone replacement therapy.
Yes, I am. You can get the presentation up. So am I ready to go? Okay, so hi everyone. My name is Omar Hassoun. I'm a third-year medical student on the ScotGem course. For our third year, we spent our time in primary care. Myself, I've been at the wonderful Greyfriars Medical Practice in Dumfries Town Centre, at which I carried out the quality improvement project that I'd like to talk to you about today. But before I move on, I'd just like to thank Dr. Matt Starowska, who was my GP supervisor and was part of my team and helped me throughout as well. So before I go on and just sort of talk about what I did and the changes that I made, I'd really love to share with you a little bit why I think this is an area that requires improvement and it's important to address. So if I just go over here. So firstly, the impact of hypogonadism on the patient, the sort of negative effects are endless. However, some to mention, we've got the physical effects like low libido or energy, sleep disturbances, or the mental effects. Many suffer from sort of low mood and depression, unfortunately, or the social stigma that comes with hypogonadism. And last but not least, we've got the comorbidities. These include diabetes, hypertension, and osteoporosis. So this is why we think it's essential to optimize response to therapy and ensure that patients are monitored well. So what about DRT itself? Is it a safe drug? So when we talk about safety of DRT, there are two concerns that always pop up, and these are cardiovascular risk and prostate cancer risk. Now, unfortunately, the research in this area is rather conflicting. So there's a lot of uncertainty happening around this area. So that's, again, why we believe it's a crucial area that we monitor to ensure patient safety. Lastly, I guess no QI project can be complete without mentioning some cost-effective improvement. And for hypoglycemia treatment, if you can see on the left, we've got the cost of administering and monitoring TRT sitting at £687. However, that's outweighed by a healthy sum of 3,732 of cost savings in reduction in costs when treating hypoglycemic comorbidities, if the patient is untreated, that is. So when we started the project, we wanted to see whether if there's regionally we have other practices have tackled this area, and if we can learn from them something and perhaps adopt their approach to tackling this area. Unfortunately, as you can see, no practices had any recall protocol for patients on TRT in place, and 5 out of the 6 believe that this is also an area that requires improving. So there's a lot of sort of room for us to share our work and improve this issue regionally. So now we get to our practice at Greyfriars. So at our practice, what is the monitoring like? We, after we did the research, sort of database search, we found 26 patients on TRT, only 1 of which had all the required monitoring in the last 12 months. So again, there's a lot of room to improvement in this area. And this then takes on to the project's aim. So for our project, we settled for 60%. So by May 21, we wanted 60% of patients on TRT to have their annual monitoring done in line with the British Society for Sexual Medicine guidelines on adult testosterone deficiency. So when we're thinking about our aim and how to achieve that aim, we wanted to break down the problem, understand the root of the problem and the factors that are contributing to the problem, and perhaps how we can then address this issue. And to do that, we used a variety of quality improvement tools, process mapping, stakeholder analysis, cause and effect analysis, and the list goes on. I did provide one example here, which is the stakeholder analysis, and that was important to identify the key stakeholders that would help facilitate the project from the outset. So then the QI tools then culminated in the development of the driver diagram. So we have on the left, the big green box is our aim. Then the 3 big blue boxes have the primary drivers. So we identified that the monitoring process requires improvement, that we can also work on staff awareness of the requirement and of monitoring requirements. And thirdly, we can also address patient knowledge on the issue in order to achieve our aim. That then led to many changes being generated on the right with the blue boxes, 3 of which we chose to use and test to achieve the aim. So what are the 3 changes? Number 1, we thought we can use the existing recall system at the practice for other long-term therapies such as DMARDs and PSA monitoring. Number 2 is to create a blood group template on Ordercom that provides a list of the tests required. And 3, a patient information leaflet on TRT, its side effects, and the required monitoring. So if I could just quickly go through the changes and tell you how we got on with them. So the first one, as I said, was the recall system. We did consider creating a whole new recall system. However, if it's not broke, don't fix it. And the recall system at our practice is quite effective as it ensures that all patients are contacted several times to make sure they have received the reminders. So we then used PBS cycles to develop a letter that had the correct content and conveys the right message that was sent out to patients to remind them that the monitoring is required. So we then, to measure this change, looked at the number of appointments booked by patients after receiving the reminders through the recall system. And if I can just look at this graph, so we've got on the vertical axis is the number of appointments booked, and on the horizontal axis is the project timeline. And you can see once the letters were sent out, there was a steep increase in the appointments booked by patients. So that lets us know 2 things: that the recall system works, which is great news, and that the letters are an effective method of communication for our patients at the very least. So second change is develop an Oracom blood group template with all the required tests. So we reviewed the data from the last 12 months. And in fact, if I can just bring your attention to this bar graph, and you can see the numbers at the top are the percentages. And these are the percentages of patients that have had individual tests done in the last 12 months. And there's a lot of variation here, which told us that a lot when tests are being done, staff are not very aware of what tests have to be done. So we created a template that you can simply click on and it will choose the right test for you without the need to know the monitoring requirements. And that can apply to medical staff or non-medical staff, which is also useful. And finally, now, the project will not work without the patients picking up the phone and calling and booking an appointment. So we wanted to address patient motivation and sort of perhaps make them understand the importance of the monitoring. And so we developed this patient information leaflet. And we covered areas like what is testosterone, why is it needed, the side effects, why is the monitoring required, and so on. And we worked closely with the endocrinology team here, which were very helpful in sort of helping us make sure that we have patient-friendly design, patient-friendly content, and we deliver the right message. So how good was that patient leaflet? So for that, we carried out 2 surveys. One was before the patients read the leaflet, and the second was after reading the leaflet. And we assessed their sort of confidence on a 1 to 10 scale, a Likert scale, and we used the averages to make this diagram. And we wanted to see how confident they are in different domains. So the 5 corners of this diagram have the different sort of areas that we assessed the confidence in. And you can see there was an overall improvement in all areas. Most notably was in the confidence in what the monitoring involves, which was great to see as that was the main area we wanted to address. So to then assess the sort of efficacy of all the changes put together, we wanted to see the percentage of patients that had all the required blood tests, blood pressure, body mass index, and measurements done as per guidelines. And so through our data, we did the data research weekly. And again, we did this on a cumulative chart. So on the vertical axis, we've got the percentage of patients that had all the required tests done. On the horizontal axis, we've got the timeline of the project. The blue line represents 3.9%, which is the one patient that had all the required tests done in the last 12 months, while the green one represents the new patients that had DRT monitoring done as a result of our project, and the yellow line is our aim. And we were very happy to see an increase from the 3.9% to 65.4%, which means we achieved the aim. As such, recommendations include implementation of the recall system, implementation of the Oracom blood group template, and that the patient information leaflet is handed out to all new patients in the future to aid in future monitoring. So, in conclusion, our project aimed to test various changes to improve DRT monitoring, improve health outcomes, economic outcomes, and patient safety. We hope that the material we created in this project can be then used and shared with other practices. Indeed, there are limitations, there are strengths of the projects, so I'm sure they can learn from that as well. And finally, raising awareness of hypogonadism. I appreciate this sort of talk is not about hypogonadism, but from talking to patients, talking to clinicians, there seemed a lot of, sort of uncertainty around how it might manifest, and that caused a lot of anxieties, which I hope I can sort of convey. Thank you for listening, and any questions?
The only fault I can find with that was the misspelled receiving.
Oh.
Fabulous talk. Right, open for questions. Right.
Why 60%?
That's a good question. Okay, so it's actually 2 reasons. First, it's quite technical in the sense that so TRT is administered in different preparations. Most commonly in the UK, we've got the transdermal, so the gel, and the injection. The cohort of patients at our practice is, again, gel and injections. For people on the injection, the monitoring should be 2 weeks prior to the next injection. Now, these injections are usually taken in 3 monthly doses. So that meant that a lot of these patients were not able to come in to get their injection because outside the time frame of the project. More importantly, at our practice, due to COVID, we had a massive backlog of sort of monitoring to catch up with on other conditions. The blood appointments were saturated, and so that took a lot of resources. In addition to that, we've got the vaccination program as well. So we also didn't have the manpower so we thought we'd test it with 60%. If that's successful, we're hoping for 90%, 95% by August 2021.
Why 60?
60. So that takes into account the people on injection. Yeah.
Okay, anyone from online like to ask a question? Don't see any hands up. Okay, anyone from the audience? Another one from Mike.
Yeah, because there's an awful lot of detail that I can't see. Can I just ask you, did you include patients and stakeholder planning beforehand?
Yes, absolutely. It was very important. I mean, they're pretty much the key piece into all of this because if they don't want to come into the appointment, then pretty much can't do anything about that. So I had to speak to patients from the outset. And then especially when it came to the leaflet, there was a lot of sort of communication with patients, understanding of what they think about monitoring. And that's why I felt that, especially what I mentioned in the end, that a lot of them sort of struggled with for a long time and felt that something hasn't been addressed for a long time, not just the monitoring, but also their condition. Like they didn't understand it as well, they didn't appreciate the side effects.
Okay, Fiona?
You had a lot of change ideas there, and you said you were realistic and selected 3. Is there any plans to look again at those other change ideas and thinking about implementing them?
Yeah, so one of the other change ideas was a staff presentation as well, which I eliminated from this simply because the practicality of sort of implementing that in the future is not that realistic, or it's not very practical. It needs someone who's going to remember to get that presentation out and give it in the way, and they need to have knowledge around this. So I guess future projects can look at, or future tests of change can look at how we can implement something other than a presentation, perhaps again like a short course or some sort of poster, or even my poster we created here can be given just to raise awareness that this is an issue that needs continuous sort of monitoring.
I'm going to say that my only surprise is that there were 8 patients who were able to resist your charm and didn't pitch up. That was a really good talk. Many thanks to you.
Thank you very much.
Okay, so next up we have Kira Jones, other ScotGem student. And Kira's going to tell us about dermatological face-to-face or telephone consultations.
I just click on the arrow, please.
Trying to keep the fit on it.
Okay. So hi everybody, thank you for letting me present today. My name's Kira, I'm also one of the ScotGem students, and I did my quality improvement within Cairnsmore Medical Practice in Newton Stewart. And the focus of my QI project was looking at improving the safety of both patients and staff during the COVID-19 pandemic by reducing the number of face-to-face consultations. Now, we picked dermatology patients in particular because primary care sees over 13 million dermatological cases annually, and we wanted to have the biggest effect on the system. So just a little bit of background. I'm not going to go into that huge detail because we all know how coronavirus has affected us all. But in December, when I first started the project, it had contributed to the death of 1.6 million, infected 70 million, and it cost the Scottish Government 1.49 billion in health and social care costs. At the time in primary care, it was essential to reduce contact between patients and staff by effectively triaging and switching to consultations by telephone. And at the time, we also seen a huge increase in the use of smartphones to send clinical images, which was a key area of target for the project because it was a new concept for both the practice and the patients. And there's lots of evidence out there that shows that telemedicine can be beneficial. Things like using it for urgent dermatology referrals, where a consultant dermatologist would review the images within 48 hours and either invite the patient back for assessment or discharge them. And evidence shows huge cost savings in both consultant time and materials from reducing the number of procedures. So prior to this project, over 50% of the weekly dermatological consultations were still being seen face-to-face, and that was a result of incorrect triage or because of telephone consultations with poor or no supporting images, so the patients were having to come in anyway. So the aim of the project by April 2021 was for less than 50% of the total number of dermatological patients to be seen face-to-face. And this is in line with guidelines from Health Protection Scotland and local position updates. We hypothesised that if we could improve both the quality of images, of patient images coming into the practice, and also improve the confidence levels of reception staff who were triaging the patients, then we could reduce the need for the number of face-to-face appointments and thus decrease the transmission of COVID-19 in the practicing community. So like Omar, we've used a lot of quality improvement tools like process mapping, stakeholder analysis, fishbone diagram, force field analysis, and driver's diagram. I've got one example here of the process maps. We mapped out the ideal patient journey from reception phone call to end of consultation, and this was used as a template to highlight any discrepancies within the current system. And these discrepancies could then be analysed for probable causes and generate a number of change ideas, which we put into this driver diagram, and they're in the column at the end there. 3 of the change ideas were chosen just based on project timescale and also which ones would have the biggest effect on the secondary drivers and the primary drivers and ultimately lead to achieving our aim. So these are the 3 change ideas that we chose. So 1, to set instructions to standardise images and provide instructions to patients that meet this criteria. 2, to create a patient information leaflet to support image taking. And 3, to create a reception flowchart for triaging dermatological patients. So the Plan Do Study Act model was used as a problem-solving method to inform the test of change. The first 2 changes were looking at improving the quality of images, and the third looking at improving the confidence levels of reception staff. So this is the first change. Through reception staff questionnaires, we realised that patients were receiving useful information from the receptionist for sending in images, but it varied in content and amount. So we decided to pick 4 key instructions to provide to patients over the telephone, focusing on things like framing, asking the patient to take a photograph up close and far away so we knew what we were looking at, to pay particular attention to the flash and the focus of the image, and also if they could use a scale, so we were able to size the presenting complaint. And that would be asking them to use things like coins or measuring tapes to be included in the image. Now this is highlighted on here just to show that the clinician said that this would be the greatest addition to the photograph. So for change 2, we created a patient information leaflet, which included the 4 key instructions. We found from change 1 that patients might not be retaining the information over the phone, or they were phoning up for consultations in their car or getting the kids ready, so they weren't remembering what they were told. So this could act as an alternative form of public communication. The problem with leaflets, we couldn't get it out to everybody, so we ended up posting the same information on the practice Facebook page, on the screen in the waiting room, and also on the practice website, which could act as signposting for patients. The third and final change was for the reception, and this is the helpful pathway to help triage patients. The red, amber and green corresponds to the severity. So the receptionist has to decide, is this an urgent problem? Does this person need to go to A&E? Or does it need to be seen face to face? Or if it's not urgent, can we send the patient to the pharmacy and use the pharmacy first scheme for things like cold sores, itchy scalp, fungal nail? Or does it need to be seen in practice but more routinely? And these are the type of things we'd be encouraging the telephone and the images for things like skin lesions and moles, eczema, psoriasis. Or does it need to be seen face to face because the patient can't send in any images or it's in a private area? And there is evidence that the right questions are being asked. On the booking system, there's notes from the reception saying patient can't send in the image, or it's in a private area, things like that. So looking at the results, this is a run chart of the outcome data. showing the percentage of dermatological patients seen face-to-face on a weekly basis. The green dots here represent the baseline data, and the green line represents the baseline mean, which has been extended to identify variation early. Interestingly, all points after the initiation of the project fall under or on baseline mean, which suggests a positive variation from the starting point. And 9 out of the total 13 test weeks fall under the aim of 50%, with the most occurring after the introduction of the 4 key instructions. To say this was the big step here was when Dumfries and Galloway experienced the highest number of COVID cases. So realistically, we're looking at the points at the end of the run chart, but we're still achieving an aim of 50 to 60%. Another run chart looking specifically at telephone consultations that included images, with the idea that if more telephone consultations that included images could be dealt with remotely, then we could assume that the quality of images had improved. And you can see a difference from the baseline again in the green to the test weeks, with 7 of the test weeks achieving 100%. The bar chart looking at the confidence levels of the reception staff before and after the project. And you can see a real right shift in the graph from an average of 7.5 to 9.2 out of 10 using a Likert scale. 100% of reception staff said that the tool was helpful, with one commenting saying it was useful for support and training despite the amount of time how long they've been in the practice. In conclusion, the 2 focuses of the project were achieved to improve the quality of images and to improve the confidence levels of reception staff. 3 tests of change were able to reduce the number of face-to-face appointments, and the practice are really keen at keeping telephone consultations going, just to stop the floodgates of patients coming back in when the restrictions start to ease, and also as a convenient way for an alternative for patients. So there's 3 recommendations from this project, and that is to continue to embed the 4 key instructions, 2, to communicate the patient information leaflet through the different means, and also to implement the dermatological triage pathway. And that's it. Thank you for listening.
Now, open for discussion. Do we have anyone in the audience? Lots of claps coming in here. Kieran, do you think, is there a sort of limit to the number or percentage of cases that could be dealt with?
Yeah, so that's
is there a sort of ceiling?
That's something that we considered. By number, it just depends on the week and who's presenting. But the practice does have a low threshold for bringing people in for face-to-face anyway. So if they did start with a telephone consultation and we were able to get a history from someone over the phone, it would make the face-to-face appointment shorter if they did have to come in.
But 50%, I just have this kind of feeling that it's never going to get better than
50%. Probably not, no. The original aim was 100, but we thought that was a bit too.
I also wondered when we were speaking about whether or not a consultant dermatologist looking at these images might have had the same or a different view. Because these were GPs who were,
yeah, this was GPs.
GPs with experience in dermatology.
Just everybody. Well, they didn't have experience with images. This was the new thing that we're getting used to. It was just used as an aid to the consultation rather than definitive.
Yeah, it's interesting, isn't it? Because I'm struck whenever I send an image to Lindsay Yo, she always gives me an answer on an image, and nobody's ever seen one of my patients face to face.
Yeah.
So, interesting. Okay, anyone else with a question? Question in the audience? Do I have one? Who's with a hand?
Gillian again said, how did you make the connection with community pharmacy on pharmacy first option?
So we have a pharmacy team in the practice. So they already have a pharmacy first booklet in reception. So I just spoke through it with them and they helped me pick what conditions.
Do you have any idea whether any serious condition was missed as a result of this?
No, I don't have any idea on that. No.
So there's nothing.
I did go through each image individually, and I can't see that there was anything that was missed. No.
Ken's got his hand up.
Ken, hand.
Yes, my hand is up. Hi, Kira. Thanks for that. It was a great presentation and great project. Now, this might not be relevant to you, but I just wondered if it was fairly new for the practice to be using photography in this way. Was there any talk about how the images were stored and the confidentiality aspect of it, especially if you're asking to take a picture quite far back, you might be a face reveal, etc.
Yeah, so that's something that we considered when we started the patient information leaflet, was including a disclaimer on there saying that when she sent the images, the reception staff would be seeing it and then it would be stored on their patient records, and then it's deleted. So they are aware that people might be seeing it, and obviously we don't have control of when they're sending it over the internet via their own emails. But it was something that we highlighted, yeah.
Okay, thanks.
Okay, very good. Anyone else from online? Anyone from our audience?
I have one.
Caitlin.
I was just wondering, is there any spot for sort of your older patients who maybe aren't quite as techno friendly in terms of if you're asking somebody to take a photo on a smartphone and emailing it in, are you just accepting that some people just won't?
Yeah, so we did consider that, and we carried out a patient feedback day where we spoke to all the patients that were coming into the dispensing practice just to pick up their prescriptions, what they thought of the leaflet, what they thought of the scheme. And we got feedback from people all the way up to the age of 86 who said that they've got a smartphone and were able to take pictures. There was obviously, of course, some that didn't, but we're aware of that, and that would justify a face-to-face appointment at the time.
Thanks. Okay, I'm going to close it there, and thank you very much. Presentation number 5. Hilary Dalgleish, waiting in the wings, I hope. Hilary, you're a paediatric nurse and your title is implementing a Watchers bundle on the children's ward. Over to you.
Yeah. Thank you. I'll see if I can share my screen. Is that showing up for everybody else? It's not coming up the way I expected it to, but
we can see it.
You can see it. Okay, we'll go with that, see what happens. So yes, I'm Hilary Dalgleish. I'm a paediatric staff nurse on the children's ward here at DGRI, and I'm going to be talking a little bit more about our project implementing a Watchers bundle on the ward. So I thought I'd start off just talking a little bit about who our watchers are. And in paediatrics, we use WATCHER as an acronym for who are the children having extra or expert review. And we use that along with an outline that Glasgow, the Royal Hospital for Children in Glasgow, created another mnemonic for 4 broad categories of patients who would class as watchers. So there's no set criteria as such, and it is quite a broad definition that can encompass various different scenarios, but that's intentional as we want staff to feel comfortable highlighting their patient as a watcher without feeling that they have to fit specific criteria. So the first category that Glasgow developed was C, being cause for concern. And one of the ways that a patient could hit that would be with an elevated pews. However, that does require an element of professional judgment, because not every child with an elevated pews would necessarily be a watcher. And initially when patients come through the door, particularly the younger children, they can be quite distressed, and that can create quite a high pews, which doesn't help by the fact we're now coming towards them wearing masks and visors and things. So it's not a case that every patient with an elevated pews, would become a watcher. The second criteria or category is patients at risk of rapid deterioration, and this is probably where most of our watchers come in, particularly within the high dependency level of care bracket, as we provide high flow and CPAP and look after patients who are in DKA or are on aminophylline on the ward, and we're seeing more and more of these patients coming through the doors at the moment. The third category for R is receiving complex treatment, and prior to COVID, most of our watchers in this category probably came from those receiving infliximab infusions, but at the moment that service is provided by our community team, so we don't have as many patients in this category. The final one is patients who are at elevated risk to self or others, and sadly this is after high dependency level of care where most of our patients come in, where we have those at risk of absconding or displaying challenging behaviour, self-harm or suicidal ideation. And unfortunately we've seen a large number of young people coming in with self-harm or suicidal ideation and being a watcher as a result of that. So moving on to talk a little bit more about the actual project itself. So prior to launching the bundle, Watchers was terminology that was already used on the ward, but not consistently, and there was no formalised sort of process to go along with that. So back in 2018, McQuick, who are the Maternity and Children's Quality Improvement Collaborative, they released their core measurement plan, and introducing a Watchers bundle in paediatric areas in Scotland was one of those core measurements. So I became involved in the project in April last year, and around about that time there was a few of us looking at different ways that we could improve situational awareness on the ward, which the Watchers bundle kind of tied in with that, along with a couple other interventions which I'll mention later on. In terms of research, there was a study done in Cincinnati Children's Hospital back in 2013 by Brady et al. And they implemented a similar process, but on a much, much larger scale. They've got 523 beds compared to our 24. But they found that the process that they implemented resulted in quite a reduction in the unrecognised clinical deterioration events and unplanned transfers to their critical care, as well as significantly improving situational awareness on the ward as well. So the aim for this project was to achieve 95% compliance with the bundle by June this year, and that aligns with the McQuick aim for the project. We set that aim about April last year, and the bundle launched in July. But like with many things this year, it hasn't quite been the year that anybody planned, and there's been a lot of unforeseen challenges on the ward. So we haven't achieved that aim yet, and I don't expect us to by the end of this month, but we have made some really good progress towards it. So this is what the Watchers bundle looks like. At the top there, you can see the criteria that I mentioned earlier, and underneath that is an area for staff to highlight the reason why they're putting a child on as a watcher. And underneath that again are the tasks that we ask the staff to complete when starting the bundle. Thanks to Suzanne Tate, we managed to get a Watchers flag created on Cortex, which displays as a red W on the Cortex bed space, but only in the paediatric profile. It's not on the standard one at the moment. And that is just a visual representation of our concern for that patient. We also ask staff to fill out the wet flag calculations, which for those who aren't aware is another acronym that we use in paediatrics for emergency drugs and equipment that may be required in emergency situations. And that's been really useful to have that when it's been required. On the second page, we have a section that we ask staff to consider whether a child remains a watcher at least once in a 24-hour period, which is usually done on the ward round. And if the child isn't a watcher, it's just a prompt for staff to fill out the removing watcher status part. At the bottom of the sheet there is a section for sort of communicating any key conversations when we're escalating patients to critical care or to PICU in Glasgow or Edinburgh. That's not actually part of the bundle as such, but just kept together because every patient that's getting escalated to that level will already be a watcher, but obviously not every watcher is going to be escalated that far. So how did we get to where we are now? In the initial stages, there was a lot of collaboration with other paediatric areas in Scotland to see what other people were doing, and also looking at the research that was available. So Tayside and Cross House already have similar processes in place. So we looked at what they had done and took aspects of it to make it applicable to our area, and just the complexities that come with working in a DGH and the time that we have to our tertiary centres. Following on from that, we started to develop the bundle and went through various different PDSA cycles and gaining feedback from staff to inform changes to get us to where we are just now, which is using version 7 that's been in place since December. Because we hope to increase situational awareness on the ward with the bundle, required us to liaise with our medical and nursing colleagues to make them aware of what we were doing, but also with our senior management team and our midwifery team leads who are responsible for the women and children's wing on a shift-by-shift basis, but also the capacity managers as well, so that when we're communicating our workload and putting patients on report, they were aware of the paperwork that was behind that. As I mentioned, Suzanne helped us to create a Cortex flag just to be that visual representation. And one of the other interventions implemented around about the same time was a ward safety huddle sheet, so that at every safety huddle we were just standardising the information that was given out, which had an area to include who were our watchers and why were they considered a watcher. And then a large part of what we've done is providing education to staff. Initially, there was quite a lot of education at the time of launching the bundle, but with every set of changes that has come, we've continued to provide that education to make staff aware of how things are working at present. So where are we now? As you can hopefully see from this graph, if it appears, we've had quite a range in compliance really since the bundle was launched in July. We struggled with compliance initially, and after looking at the data and speaking to staff and getting feedback, we realised that the bundle wasn't really fit for purpose initially. So it underwent some major changes in December, accompanied by some education, and we saw a significant increase in compliance. Then over the last couple of months, compliance has dropped a little bit, but we are starting to sort of be on the rise again, and we hope that will continue. We feel that kind of reduction in compliance was probably due to another major quality improvement project on the ward, which is just launched in May, the Sepsis 6 bundle, which as a QI team has taken a lot of time and effort, but has also been quite a major change for the ward. And as well, we've actually seen a massive increase in the number of watchers that we have per month, from 7 in December to 23 in April, and I think there was more than that in May. So hopefully we're on the road to increasing our compliance now. The compliance is set by McQuick as well, so we've got 11 different aspects that need to be met to consider a bundle completely compliant. And when you look further back at the data, 100% of our watchers that are identified are appropriate, and they have been identified, and everything that needs to be done at the start has been done. But what's sort of letting us down more is the documentation of removing patients as a watcher when it's appropriate. We also gave out a questionnaire pre and post intervention. This wasn't specific to the Watchers bundle though, it also included the ward safety huddle sheet that I mentioned and also some SBAR training. And we asked staff to rate their response to the questions on a 0, like a strongly disagree depicted as 0 and a strongly agree depicted as 5 scale. So as you can see, post intervention, they did feel that situational awareness on the ward had improved. There's no data there for 3 points, and that's because they related to the safety huddles, which were already an established part of the ward routine, and it wasn't one of the interventions as such. So at the moment, we feel like we do have a bundle that is fit for purpose. However, we are always open to making changes as we look at the data and we get feedback from members of staff. We feel that staff engagement is improving, and from speaking to different people, they do feel like the bundle offers value to the ward, particularly when communicating our workload out with our ward area. As I mentioned, the staff do feel that situational awareness has improved, but that's not uniquely due to the Watchers bundle necessarily, because there was a few things implemented at the same time. We are finding that our watchers are being consistently communicated at all huddles and handovers, which is really good. And as I mentioned, having the wet flag calculations has proved really useful, having them calculated already prior to any deterioration, where they can just be transferred into the whiteboards in the room. So what are the next steps? Ultimately, we want to achieve 95% compliance, and to do this consistently, and hopefully we are on the way to that now. We want to continue education with staff and sort of more recently, particularly sharing our progress in a more visual way. It's all, fine and well us being able to see the data and see where things need to be improved, but if we don't share that with staff, we can't expect compliance to necessarily get any better. So we've started to visually share our monthly compliance on the ward and share next steps to hopefully improve that. Recently, we've had a member of medical staff from another area in the hospital who has been keen to look at our bundle and adapt it for their ward area. So going forward, we are happy to share our project with anybody that might feel it would be useful for them. And that includes out with, DGRI and other paediatric areas in Scotland that as yet don't have anything. We've started to share that with them as they've asked for it. So just before I finish up, I just wanted to say a massive thank you to everybody else that has been involved in this. It's not been a project I've done by myself. Ailey and Sharon are two other staff nurses on the ward who have worked really hard on this project as well over the last year. And I just wanted to say a massive thank you to Laura and Susie, who supported us initially from the QI team, and more recently to David. This is the first quality improvement project I've been involved with, and as such I've had an awful lot to learn, but really glad for all the support that we've had from everybody. And that is everything from me. Happy to take any questions that anybody would have.
Hilary, that was a very nice presentation, very nice exercise as well. So we're now open for questions. Anyone in the audience here? Or anyone online? Can I see who's online? Yes. Yeah. So, Hilary, can I just, while they're thinking about it, can I ask the question? You give us the percentage, I think it was roughly 57% clients with your bundle, was at the last count. Yeah?
Yeah.
But is that 57% of what? Is it, I don't know how many patients you had on the at the time?
So the compliance is, it requires 11 different parts of the form being fully completed to consider a bundle compliant. So it's overall compliance with the entire bundle when a patient is started as a watcher. So it's kind of, when you look at different aspects of the data, 100% of our watchers are recognised and are, dealt with appropriately at the beginning, but it's just this removal section that's sort of bringing us back. So
okay, just give me a feel. So at any one time, how many patients do you have on a ward, and how many patients of those are required to be watchers?
So it varies very much shift to shift, but for example, last night we had I think we had 8 patients and there were 3 watchers. There's usually at least 1 watcher on every shift, but we have had up to 5 watchers at any one time out of sort of 10, 12 patients. So we've definitely seen a big increase in the number of watchers compared to the number of overall patients probably in the last couple of months. And whereas back in sort of December, January time, it was maybe, 1 every couple of days that was considered a watcher.
Okay, now we've got some questions coming in. I've got Mike in the audience here.
In the presentation, you mentioned that situational awareness was improved. Could you tell me what that means?
So prior to the Watchers Bundle, at our safety huddles, we more kind of discussed, every patient and what was happening that day, but not necessarily everybody knew who the patients were that we were most concerned about. So we've improved situational awareness in that respect within, our nursing team, that we're discussing the patients that we are concerned about, so that another nurse that's maybe working at the other end still knows what's going on in the ward. But also when we're communicating our workload to the senior midwives, who they phone for an update every shift, we're able to say, well, we might only have 6 patients, but we've got 3 watchers and 3 people we're really concerned about, just so they're more aware of what our acuity is. And that works too, in terms of the capacity managers. So it's just in general staff being aware of what is happening on the ward, rather than it just being 6 patients.
Okay. Okay, one final question, Kirsty Burns. Can't hear you. You're on mute, I think. Callum, can we help?
I shall see what I can do.
Kirsty, sorry about this. We can't hear you. Can you hear us? You can hear us, okay. We're just going to try and do something.
Pop it in the chat.
Kirsten's not actually muted at all, so I don't know why it's not coming through, I'm afraid.
Kirsten, can you pop it in chat?
Short question.
Did we get that one from David as well, Chris?
Is it what?
Is that one from David as well?
Okay, we've got one. Here's a question from David Adamson. Your aim was to achieve 95%. How do you aim to get up that value?
So I think our biggest aim for that is to show staff what our compliance is at the moment and how we can change that, because our focus has been so much on the sepsis bundle recently, while we've been doing the data, I don't think we've maybe been as good at sharing that with staff, and they, as a result, they haven't been aware of what we can do to improve it. So that's definitely one aspect of it, and I think we're going to put out another sort of bit of education as well. We haven't had any major updates to the form recently, but we've had a couple of new staff start, and obviously there'll be a medical changeover soon as well. So when that happens, we'll update everybody on where we are and how to use the bundle, and hope that if anybody has any questions, they can come forward to ask us.
Okay, Kirstine, you're going to have to forgive me. I'm going to have to cut you off because we've run out of time. It's now just about 5:02. I would like to thank all our speakers for these very nice talks today. So a big round of applause for everybody. The judges are going to go and have a little chat amongst themselves. I believe, Ken, you're going to say a few words while we're away. Ken?
Yes. Can you hear me okay?
Yep.
Yes.
Okay, good. Okay. So I appreciate a bit behind time, so I won't take too long. But like Chris, I just want to thank all the speakers for 5 fantastic presentations, so well done to all of you. And also to the rest of the people who submitted posters, 41 I think was the number. So well done to all of you for that. And really good to see quite a breadth of participants. So we've got medical students, HPs, nurses, junior doctors, so that's all fascinating. Looking at your the 5 presentations, I'm going to quickly just run through them. Like everybody else, pretty deeply depressed about gentamicin, and that's nothing to do with the presentation, but just the fact that it was an issue when I was a junior doctor back in the 90s. So there's something really complex and wicked about gentamicin, but well done to the 2 of you for taking that one on. And there's more work to come there, and how we resolve that one, I'm not too sure. Laura, you were stymied a bit by technology and we didn't get to see your film, which is a shame, but thanks for that bit of work to raise awareness for around AHPs and the work they do, and to bring them together using social media is really, it's a fascinating bit of work, so well done there. Omar and Kira, I'm going to take you together purely because you're ScotGem students, and it's great to see you doing your bit of improvement work and very different bits of work, but you both demonstrated a real kind of rigour to follow the process, and both achieved really good outcomes. So well done to both of you there. And Hilary, yeah, that was a great piece of work. I liked the fact you stole from other boards. Again, you followed the process. You demonstrated real teamwork. And I have to say that the one, I've not seen it before, but I loved the curtains opening in your presentation. That was a new one for me. So well done. Just to kind of finish off, because I know the judges need a few minutes to make their mind up, but just for me, there's improvement is that important part of all our jobs, but there is sometimes a concept that it's something that comes a bit later on in your career, and I think we've had demonstrations today that that's not the case. And it's so important that the people who are driving a lot of improvement are those that are right in amongst it and know what's going on. So for me to sit in my ivory tower and say fix gentamicin is all very good, but actually it's you guys in there prescribing it, working with teams that can do the work that actually gets it to a better place. And that understanding your system, the organizational part of improvement, to really know how it works so you can see the bits that need to be improved is really important. I guess the second bit is just the tools you use. So we saw a bit of IHI method, model for improvement there with PDSA cycles and driver diagrams. There was an audit, and there are other tools that out there that we can use for improvement, and just picking the right bit of methodology that fits your particular project is really important, and then following the process. And you'll hear improvement folks say that over and over again, but it's so important to not deviate, because then it just all kind of tends to fall apart. There's a relational bit as well about knowing the system, but knowing the people in it and understanding how difficult it can be to change, for people to change their behaviours, the culture around a ward or a hospital, And again, there's a big bit there about gentamicin. How do we get people to really change and get to prescribing it in a safer way, and how important it is to just understand it's actually quite hard to change. And the final bit really for me is that personal bit. That's how we are in amongst doing that project, because Hilary mentioned the teamwork, and you can't do these things on your own. You need other people, but you need to bring them on board. You need to do that relational bit with them to get the support to move it forward, and you need to be able to recognise yourself when maybe there's something you've gotten wrong. Show that bit of vulnerability, take you down a slightly different route to get to the result you want. And I think that all of that was demonstrated in the presentations today, which were fantastic. So well done to you all. Thank you for that. I'm hoping we're at the point of a decision being made in prize giving, and I'm going to hand back to Chris and Maureen for that, because I'm afraid I can't do the prize giving from where I'm at. So thank you all.
Thank you, Ken. I've no idea whether you can see or hear me anymore, because Callum has left the room, so I can be seen, which is great. So we're still waiting on that final judgment bit. So I kind of want a drum roll to happen here. And I can't echo strongly enough that how impressed I have been with all of the presentations today. You guys have done a fantastic job. There's no way that when I was a student, I would be able to stand up and to give that degree of rigour to the work that I was doing around improvement. So fantastic job, and I'm really, really impressed around it. And I think that it doesn't matter where you start with quality improvement. It is a journey. As Ken rightly said, this is 20% to do with the tools and the techniques that you use, and 80% to do with people. So all about relationships and how you get people to change. So the most important bit around any improvement work is about how you use the psychology, how you use your knowledge of people and how they change, who's going to work with you at the beginning, who are the people that find that really, really difficult and why, and what are the kind of things, the motivational techniques that you need to use in order to bring them on. And as we get more experience with that, you recognise that actually it's not the really enthusiastic, energetic bunny that will bring on the people that have reservations around some of the improvement work. It needs to be people like them. So if you can get the person who has maybe some queries around what you're doing and get them to a place where they get it and they're supporting it, they will bring the next group of people with you. So if there's anything that you learn out of that, is tools and techniques are absolutely brilliant, and they help you to understand what's going on, why it's going on, what interventions are going to work, and why. Get on top of the people, and I think that I've heard that through every presentation today, that you've talked to your colleagues, you've involved the patients and the others in the community around that, and that is just so important, learning for moving forward. So in terms of our categories, and I feel as if we're in Rome waiting for the right colour of smoke to go up, and the right colour of smoke is heading this way, I believe. Wow. We're just about to do the presentations, and as you know, we were looking at 3 different aspects. So there's one is the best oral presentation today, and we were using scientific methodology to get there, and I hope that the judges, and we had 4 judges today, so we had Professor Chris Isles, Dr. Mike McMahon, we had Graham Bryson, who is our Director of Pharmacy, and we had Natalie Morell, who's the Head of Organisational Development and Learning for the board. And they've all been assessing the contributions that you made today. Now they've disappeared, and they will shortly be back. But what we were looking for is not just about how well you presented in terms of your style, but we were looking at the the issue that you chose and how you presented it to us to make us feel as if that was really important and a really important issue. You know, the tools and techniques that you used around that and how you presented those were important to us as well, as was looking at the results. So knowing where you were starting from, knowing where you got to, and what still needed to be done. So lots of questions came around that from the room and from the chat, and that's why. So I'm going to present, first of all, for the People's Choice winner. And that People's Choice winner goes to Hilary Dalgleish. Hilary, well done. A virtual shield and voucher will be on its way to you, and hopefully we can connect at some point and pass that on. So very well done, Hilary. Congratulations.
Thank you.
And next we have the poster winner, Omar. And the oral presentation winner.
Yeah, the oral presentation, the judges were split and we decided to award it jointly to Kira and Omar.
Oh! Well, all that remains to be said is fantastic work, everybody. Really, really well done to all of the winners. But I think that for me, we're all winners because you guys are out there raising the issues, improving the quality of care on a day in, day out basis. Just keep doing it. If you need support in doing that, then come and have a chat with some of me, maybe me, some of my colleagues around patient safety and improvement team, and we'd be delighted to help you on your improvement journey. So well done, everybody, and thank you to everybody that's worked behind the scenes to make this work. So Callum and Leslie are in the room with me, and there's been many other people that have put it together and promoted the event. So that's all that I want to say. Chris, do you want to have the last word?
Just well done, everyone.
Yeah.
I enjoyed that. Thank you.
Yeah, great.